Good morning. I'm going to talk about monoclonal antibodies for infectious disease broadly. I won't cover everything, but I'll talk about what I think are some important topics. And I'll start with kind of one of the first drugs that got into clinical practice, a monoclonal antibody for treatment or prevention of RSV in preterm infants, developed by AstraZeneca. They made a mutation in the FC portion of the molecule that allowed the antibody to last a long time, the YTE mutation. Then they demonstrated that this could prevent RSV in these preterm infants, and the drug was approved for that usage, which is an important milestone in monoclonal antibody development. The next thing that's worth talking about is Ebola, and I think everyone's aware that the gravity of Ebola infection. And what we saw were comparative trials of a unique antibody called ZMapp, the antiviral agent, small molecule remdesivir, and then Regeneron's monoclonal EB3 and the Ridgeback NIH monoclonal mAb114. And the bottom line is, if you look at the far right, you see that when this drug was administered earlier in infection, that the benefits were visible, especially for Regeneron and mAb114. And those drugs are kind of on the verge of usage for this particular infection. Now, I would say that the most knowledge and the most education, most information has come from our search for monoclonals to be used for HIV. And HIV is a much more difficult pathogen to deal with because there's a kind of an arms race between the HIV virus and antibody formation. Of course, the antibodies are used to demonstrate infection, but those antibodies turn out to be not very helpful. And what happens is that in the untreated patient, the host continues to chase the virus, and about 20% of hosts are going to go on to develop broad neutralizing antibodies. And that's shown in this slide. There's an initial viremia. There's the antibodies that prove infection, not effective to reduce viremia. And then as the virus throws off mutations, the host immune system chases the virus. And ultimately, as I've indicated, about 20% of subjects after a couple of years will form broad neutralizing antibodies. And so the technology to study broad neutralizing antibodies and their application has been really critical in our thinking about HIV, but in our development of work for COVID. And these are an example of antibodies that bind to different places on the HIV envelope. And I would draw your attention to a couple of antibodies that are particularly important: VRC01 from the Vaccine Research Center at NIH, and from Rockefeller 3BN C117. And what you're looking for in a monoclonal antibody or a broad neutralizing antibody is you want it to be broad. That is, it's going to kill a lot of strains, and you want it to be potent. That is, you can give a little bit of the antibody and it still kills these strains. And you want to be able to make it in a lab, because if it can't be generated, you could never develop a clinical product. And so we took off about 5 or 6 years ago in working on the monoclonal from the NIH VRC01. We never thought it could be a product. We thought we could explore whether this agent could be used both therapeutically and for prevention. And we started developing prevention trials. And since we could not or have not been able to make a vaccine, we kind of envisioned that maybe monoclonals could be used for prevention of HIV. And Dr. Larry Corey at the HVTN and I at the HPTN were partners with the NIH Vaccine Research Center in what are called the antibody-mediated prevention trials. Using this antibody VRC01 in volunteers all over the world, giving 44,000 infusions of this antibody every 8 weeks compared to placebo. We used a couple of different doses. To make a very long story short, we were able to show that our hypothesis was right. The proof of concept was basically right, that this antibody given IV every 8 weeks could prevent HIV some part of the time. The problem we ran into was our kind of, not problem, the challenge is how much antibody you need to prevent infection. What we saw was we could really only prevent viruses that had in a test tube extreme sensitivity to the antibody, that they required less than 1 microgram per mil to be neutralized. So viruses that were more resistant to our VRC01 antibody broke through and caused infection. So kind of glass of water is half full. We proved the concept, we believe, but we also showed that it's going to take a lot more antibody or a combination of antibodies to make a pre-exposure prophylaxis product that would be the alternative to a vaccine. This is just a slide that kind of reemphasizes what I've already said. If you look at the blue line of less than 1 microgram per mil, you see that more than 80% of the time we could prevent the breakthrough of this particular viral strain. And this is across all clades. This is clade independent. It just has to do with how sensitive the virus is to the antibody. So our conclusion from this very large body of work is that a single antibody is never going to be sufficient for pre-exposure prophylaxis. And this heat map shows combinations of antibodies. And the combination, the red means you've killed the most strains and kind of theoretically at the lowest concentrations. And our attention turns to VRC07, a variation of VRC01, PGT112, and PGF1400. These attack the virus at 3 different sites, and they give you the kind of breadth and potency where you could see a product being developed with these 3 agents. And we're exploring a clinical trial to develop these agents as PrEP in collaboration with the IAVI organization, who own the rights to several of these antibodies. You'll also notice that the VRC07 now has a mutation in the FC receptor called an LS mutation that makes it last longer. So we don't want to be administering antibodies every 8 weeks. We'd like them to last many months, if not a year. And so we would anticipate introducing mutations in the FC portion to prolong the half-life of the antibodies. And in that case, all the antibodies have to line up. So it's a pretty big challenge to succeed in this space, but it's one that is proceeding. Now, it would be wrong to focus entirely on the NIH work. I would point out that the Rockefeller Group and other groups have done great work with monoclonals, and Michelle Nuzenswag and Marina Koski are leaders of this. They have a combination of 3BNC117 and 101074, and these antibodies meet the same kind of criteria. They can be made in a test tube. They have great potency, and they have great breadth. And they have been used, those antibodies have been used successfully to take someone viremic with sensitive isolate and show you can reduce viremia for very long periods of time until the half-life of the antibody wears off. And these antibodies from the Rockefeller have already had mutations introduced into the FC portion. So they're pretty far along in thinking through both therapy and prevention with these antibodies. And so I would argue that the HIV antibody field, while it has challenges, has made progress and has made contributions. And probably the most important contribution is setting the stage for our reaction to COVID. And so I'm going to spend the rest of the time I talk to you talking about COVID for about 5-10 minutes. So from the very beginning, Larry Corey and I, we were charged to become COVIDologists. And, and a lot of the HIV people were asked to work on COVID. And we thought from our experiences with HIV that there was not going to be one single magic bullet. We would need masks and distance, behavior changes. We would need vaccines. And it turns out that spectacular vaccines could be developed and tested clinically. And we would need interventions. And those interventions would be almost certainly monoclonal antibodies and small molecules. So let's just focus on monoclonal antibodies for prevention and treatment. The monoclonal antibodies, if they were available, could offer immediate protection for those who are unvaccinated after exposure or before exposure. They could be provided to people who can't respond to a vaccine, like compromised hosts. There's about 10 million who can't respond to a vaccine or are allergic to a vaccine. These monoclonals have already demonstrated that they can stop viral replication in the nose and block progression of disease. And the concentration of monoclonal necessary for protection contributes to our understanding of what's required for a vaccine. And monoclonals, of course, then would be particularly attractive for particular populations, people living in long-term care facilities, workplaces where outbreaks have been common, such as in meatpacking plants, households where we know transmission can occur, and especially we're concerned about monoclonals for immunocompromised hosts who are likely to either have progression of disease should they acquire COVID. Now, the slowing down just a little bit, the method of developing, so again, the information that was gained over many years of working with HIV really helped with COVID. And this is the slide from Dennis Burden's group that just shows you take somebody who's had COVID, you bleed them, you isolate B cell, you isolate their blood and look for evidence of super duper antibodies. Then you isolate B cells and find the B cell that's making a monoclonal that's valuable, that attacks the receptor binding domain or some other very important domain. And you test it in a test tube to prove it's potent. And then you take it to an animal model and you show you can protect or treat the animal, and you get into human trials. And all of this happened incredibly quickly. There was no COVID, in December of 2019. And by February and March of 2020, we were already in clinical trials of monoclonal antibodies developed in the ways that I've described on this slide from Dr. Burden. And this is just a partial list that you don't need to focus on, of all the monoclonals that have either been generated or are in development. And there's a lot of them. I just want to focus a little bit on the ones that are more clinically available. And before we get into that, it's worth noting that kind of our windows of opportunity. Of course, the most important opportunity is to vaccinate people and use masks and give people who can't respond to a vaccine a monoclonal as prophylaxis. That would be our best use of agents. But then COVID is divided into stages, and the most important stage for an intervention is the early viral stage, where there's replication in the nose. And if that replication in the nose goes unchecked by the host, then the virus will grow to higher concentrations, be aspirated into the lungs, cause pneumonia and other devastating complications. Once all of that happens, if unchecked by the host or exogenous intervention, you get to a stage of pulmonary disease and hyperinflammation and blood clots, and it's a whole different disease. At that point, for most patients, the kind of intervention that stops viral replication is much less important than the management of inflammation, secondary infection, and blood clots. So we're going to focus with our monoclonals therapeutically on the early stage of infection. And that really means the first 3 to 5 days. I think I'll come in a second to description. I hope I come in a second to description of the agents that are available in this setting. The alternative to our monoclonals in that early stage of disease are small molecules. And the advantage of the small molecules are that they're low touch. For us to infuse or give sub-Q a monoclonal, then we have to bring a person into a situation where other healthcare providers are available and so on and so forth. But if we could prescribe a pill and the pill worked, you could pick it up at a drugstore, never see anyone, and take your pill and have the same benefit theoretically of monoclonal. And 2 pills that are pretty far along now are molnupiravir, generated by Merck, and Indian consortiums, and a Pfizer pill, a protease inhibitor tied together with ritonavir, and both are pursuing FDA approval at some level. Atia has a drug that's in earlier development with Roche, and Shionogi has a drug, and there are many others. So we're anticipating not just monoclonals, but also small molecules. Now, so for the monoclonals, there are 2 combinations and 1 single agent that have been approved by the FDA for treatment. And those include the Regencov combination, a Lilly combination with bamlanivimab and another monoclonal, and then GlaxoSotrivimab. And those monoclonals, as I've kind of already indicated, should be used in the first 5 days of illness, if at all possible. And what you're trying to do is give a huge slug of antibody that will get to the nose and stop replication of the virus before you leave stage 1 of the disease. And as I said, all 3 have been made available therapeutically. And interestingly, at first, they were very slow to be used, only 1,000 doses in June of 2020 of, like, for example, Regencov, a couple of thousand doses. By August, 250,000 doses, and now more than, I think, 1 million doses every 8 weeks just of that one antibody. So people are aware that for those who are at risk of progression of disease, that early intervention with the monoclonal is a really good idea. But I want to talk also a little bit about pre and post-exposure prophylaxis, because we worked very hard on this in our network called the COVID Prevention Network. And this is just one example, our BLAZE-2 study with Eli Lilly at a time when the alpha virus was the only one circulating. And we took bamlanivimab, 4,200 milligrams, and compared it to placebo in nursing home residents and attendants, where vans would drive around the United States and show up with 7 people who could do an RCT, a randomized clinical trial, within a long-term care facility. And amazingly, if you look at this Kaplan-Meier curve, if you gave placebo, there was considerable infection and progression of disease. But if you gave bamlanivimab, we had an 80% reduction of infection in residents of nursing homes. The attendants did a little less well, but it was really dramatic in the residents. And this is all before vaccines were available. Of course, monoclonals are not trying to compete or undermine vaccines. And this is just an example of their power to succeed. We did another study with REGEN-COV in households, where we took the index cases in households that we knew had COVID, and then we took the people living in the household and we randomized them to REGEN-COV versus placebo. And we showed that when we did that, quite remarkably, we could block 80% of the infections in household members over that 26, 29-day window when they were exposed to their household member. And this led the FDA to approve both a bamlanivimab combination as well as REGEN-COV combination for post-exposure prophylaxis. And they focused a lot on post-exposure prophylaxis because they felt that the study design was more powerfully proving that point. Now, more recently, and I think there might be a slide about this, with REGEN-COV, we continued to follow the same subjects, and we demonstrated that over 5 months, the subjects who got REGEN-COV that were household members, they continue to be protected by REGEN-COV with an 80% reduction in the acquisition of SARS-CoV-2 over 5 months. And Regeneron is asking for permission to use REGEN-COV as pre-exposure prophylaxis for 5 months at a 1.2 gram dose. AstraZeneca has done a trial with an IM injection, and they argue that they saw that with a mutation in the YTE portion of the molecule that makes it last longer. And they argue they also get long-term prevention of SARS-CoV-2 when they give a single IM injection of the AZ combination. So we see this kind of rounding out, and kind of the rounding out is like this. I've already told you that 3 drugs are already approved for intervention to prevent progression of disease in people who you think might go on to progression. That would be any compromised host and anyone older or with underlying disease. And that's independent of whether they're vaccinated. Of course, most vaccinated people are going to do well, but you can still give an antibody supplementary to a vaccine, even fully vaccinated and boosted people. And then more recently, as I've indicated, the REGEN-COV combination and the bamlanivimab atezolizumab combination have been approved as post-exposure prophylaxis in settings where people are continually exposed and would be at risk for acquiring the disease and progression of disease. And I've already indicated to you that the Regeneron combination looks very good for pre-exposure prophylaxis over at least 5 months, and such approval is being sought. And I've indicated to you that AstraZeneca is seeking similar approval for their monoclonal combination. And we would anticipate before the end of the year, we hope before the end of the year, that the FDA will act on these requests. These kind of pre-exposure prophylaxis agents are critically important to the 10 million or more people who cannot respond to vaccines. Every day I get emails asking me, how do I get access to these antibodies because I don't have any chance of responding to a vaccine? And these would be people mostly with solid organ transplants or other immunosuppression using agents that block B cell function and antibody formation. So we're very excited about the forward movement of these agents. Anyone listening to this call is rightly worried about variants because we cannot control what SARS-CoV-2 does. The Delta variant has been devastating in its transmissibility. That's bad news, but the good news is that all the vaccines have an effect on the variants. And what we've learned about the vaccines is they really don't necessarily block infection or breakthrough infection, but they tend, and nor do they block transmission exceptionally well, but they do block progression of disease. So it's really critically important to get people vaccinated, and they block progression of disease for the Delta variant as well. And all the monoclonals we have that are using are active against the Delta variant. Now, we're monitoring this, hoping that we don't run into new variants that resist our antibodies. And if that happens, that's bad news. The good news there is we know how to make more antibodies. So you can kind of envision if somebody breaks through with a variant that's very resistant to our antibodies, we can bleed those people and modify what's available to us because we can make antibodies very fast, new antibodies very fast. So I've talked to you for about 20 minutes about monoclonals and infectious disease, several different topics. They all have the same theme. They all look at monoclonals for either treatment and or prevention. And in prevention, they all look at monoclonals either for pre-exposure prophylaxis or post-exposure prophylaxis. We've learned a lot about how to make these agents. And my bottom line feeling is that it's kind of like COVID washed us a whole new wave of thinking about infectious diseases. And, 50 years ago, convalescent plasma, hyperimmune globulin, agents like that were very popular, but, fell out of favor because we were able to make antivirals. Now, I think monoclonal antibodies are going to be important to us in infectious disease in general, and especially for emerging pathogens, because we know how to make them and because they can be made really readily. They're a little bit expensive currently. They're a little bit hard to give, but they give us a tool that I think is critically important. Now, for the slides I showed you and what I've said, obviously this is not my work. This is the work of thousands and thousands of scientists, and virtually all the slides were borrowed or liberated from other people. It's too many people to thank. So let me thank all the people whose slides I used. So thank you for listening, and I hope you have a great day. Thanks.